As I reflected on the forum discussion question, I realized that I use a lot of asynchronous communication tools when communicating and collaborating with my students. Emails, online discussion boards, and cloud-based box sites are a few of the ways by which we exchange information. For our final segment, we will look at how everyone works together. Earlier in this module, we discussed the profession-determined roles and responsibilities of healthcare providers. Now we're going to look at an example of an interprofessional team, some informal roles and responsibilities that arise when participating on a healthcare team, and the dynamics by which teams are formed. Why are collaborative care teams now becoming the professional norm? As was previously discussed in Module 1, people are now living longer, but with chronic disease that needs to be effectively managed, and often by multiple healthcare providers, who must work together to manage several comorbid conditions. Also, evidence-based practice has become increasingly complex due to rapidly evolving healthcare. No single provider could possibly stay abreast of all the developments and apply them effectively to patient care. So, providers now refer to other providers when faced with issues or situations beyond their own scope of practice, or when greater competence or specialty care is determined as being necessary for the patient's health. Interprofessional teams have the goal of ensuring that care is provided in a coordinated and consistent manner with the proper sequencing of evaluation and treatment, all within the framework of the patient's overall developmental, medical, and psychological needs. Collaborative care teams have actually been around for quite some time. The first interprofessional care team was established in 1938 by Dr. Herbert Cooper, an orthodontist in Lancaster, Pennsylvania, to treat patients with cleft palate using a team approach in order to achieve optimal physical, emotional, social, educational, and vocational patient outcomes. Today, core members of a cleft palate healthcare team typically include the patient and family, a pediatrician, craniomaxillofacial surgeon, orthodontist, speech pathologist, and patient care coordinator. A referral network of additional specialists is tailored to the needs of the patient, including a psychologist, social worker, psychiatrist, audiologist, geneticist, pediatric dentist, neurosurgeon, ophthalmologist, and radiologist. Members of collaborative care teams often have overlapping professional roles, develop a working knowledge of the other professions, and combine the contributions from everyone to develop a comprehensive, cohesive patient care plan. Team members' professional roles and responsibilities are defined by their education, training, licensure, and clinical practice. When we work together in collaborative care settings, we also take on additional roles and responsibilities as a result of group dynamics. Some of the additional roles are formal, such as being the team leader, and healthcare teams can appoint a leader or change leadership based on the patient's needs or focus, or share leadership in order to promote the equality of all members and all types of providers. Some of the additional responsibilities are also formal, such as decision-making. In order to achieve the goal of optimizing patient outcomes in all aspects of patient care, team members must collaborate in defining the patient's problem, prioritizing the issues involved, and developing an action plan and deadlines and accountability. Team roles and responsibilities will be discussed in greater detail during Module 5, titled How We Can Work Together, Leadership and Membership in Team-Based Healthcare. But what about the informal roles, which are often unrecognized but can have a huge impact on the team dynamics? These informal roles generally depend on our personality, the life experiences, level of equality among team members, and the situation at hand. Positive roles increase team effectiveness by facilitating the completion of tasks and managing interpersonal and social situations. For example, an initiator proposes original ideas or different ways of approaching group problems, procedures, or goals, thereby moving the team forward. Another positive role is the harmonizer, who mediates differences between other members, attempts to reconcile disagreements, and relieves tension in complex situations. On the other hand, negative roles decrease team effectiveness. For example, someone who is a blocker opposes every idea or opinion without making his or her own suggestions, while a recognition seeker uses the team meetings to draw attention to him or herself by boasting about personal achievements. Redirection of team members who assume negative roles is essential to establishing a successful team, and it is often done by the leader. So we've talked a lot about collaborative care teams now, but haven't yet addressed how teams are formed. Typically, there are 5 classical stages of development, which were first described by Bruce Tuckman. The forming stage provides the foundation for the team and occurs when the team is first conceptualized and created. This is the time that the mission, team size, and membership criteria are established. The mission provides the team with unified, shared goals and should be generated and agreed upon by the entire team. The size and composition of the team are important. Small teams of less than 5 members may not provide sufficiently different perspectives, while large teams of more than 25 members may lead to the formation of subgroups, which then interferes with collaboration. During the storming stage, team members may vie for power or influence until the ground rules for decision-making are developed. The team leader must be able to handle the conflict often associated with this stage and embrace flexibility as needed. The norming stage is when the team's rules, processes, and behaviors are decided, which will allow the team to work as a coordinated unit. It is during the performing stage that the team actually functions as a truly collaborative unit, and the resulting accomplishments both unify and reinforce the team's identity. At some point, healthy teams eventually transition back to a new forming stage when they take on a new, challenging goal. The adjourning stage occurs when the team completes its tasks and disbands. Teams may also adjourn due to administrative reasons, such as budget cuts or changes in healthcare funding. The key learning points for this section are that all teams undergo predictable stages during their development. In addition to our own professional roles and responsibilities, we also take on additional formal and informal roles and responsibilities when we work together on a collaborative care team. I'd like to extend my warmest appreciation to my collaborators on this module: Annette Carley, Sarah Clough, Hattie Grunland, and Joanne Sachs from UCSF School of Nursing, Jennifer Chang from the School of Pharmacy, and Charles Rim from the School of Dentistry. I'd like to thank you for joining me on this module on roles and responsibilities.